What's your opinion on decompression?
I wish I had a decompression machine. I think that would be pretty sick. Now I think, and I don't have too strong of an opinion, just because one, I don't know too much about. I don't work with a lot of acuity, and I don't know if that's something that most people like benefit from an acute stage or not. So I'm actually curious to hear about that. And yeah, actually, tell me a little bit about that. I'm curious. Is it something that you would prescribe from more of an acute lens or more of a chronic lens, or both? And
Both. So when I was in school, decompression was something that, was a back burner. Obviously, as chiropractors, we're trained manipulation first, which, that's cool. That's what we do. I think that if there's any chiropractors that aren't utilizing therapies, I think it's a disservice to the patient. I think it goes along with that sort of model. And decompression is something that is not covered by insurance. It's not probably going to be covered by insurance, and it's pretty expensive. However, it is one of the best ways to help create space for a nerve and open up disc spacing and retract a herniation. Unlike yourself, I'm treating decent, more acute issues, some chronic. But if anybody has compressed nerves that's originating from the spine, that means radiating pain around the hips, down the legs, or in the cervical spine, down the arms. A lot of times that's going to be from a compressed nerve. Utilizing a decompressive approach is a great option. Now, there's two things that matter with decompression. It's how hard you pull and where you pull. And both are really important. So I always tell patients, they're like, oh, I went XYZ and they did some traction, some decompression. That's my first question. How hard did they pull and where did they pull? Well, I don't know. That's important because if you look at something like an inversion table, it's a great way to create space, but it's divided by your ankle to your knee, to your hip, to your lower back, to your neck. What's getting the pull, probably what's the path of least resistance, right? The difference on a decompression table is it's targeted. So you lay on this table, you can put in there how hard, and you can put in there where. So you're going to use, a physical exam, you're going to use patient symptoms, you're going to use imaging, X-ray, MRI to target that, and then you're going to progress them through weight. So for a starting lower back, you would pull them at about 60 pounds. They're on the table about 20 to 25 minutes, and it actually pumps the joint. And the way it does that is if I set it up for 60 pounds, it pulls at 60 for 10 seconds and then relaxes to 30 for 10 seconds. And it pumps that back and forth. A lot of research shows that discs respond really well to that pumping action versus a sustained hold, which is another reason on why I kind of teach an inversion table a different way than just flipping upside down. But, once you progress through the weight and get to that therapeutic dose of enough pull, which is different for everyone, by the way, it's miraculous. When I started this practice a year ago, I wouldn't have started this without one.
Gotcha.
Because of how many times my treatment with my hands alone is not going to help an acute disc or even a chronic disc. When you throw something chronic on there, it depends on the severity, right? It depends on how much compression, how old the patient is, how the disc looks. You can actually look at a disc on an MRI and see how much degeneration there is. And it's not just a height issue. The color of the disc on an MRI is going to tell you how hydrated it is. So the disc is very much like a sponge. So if it's very well hydrated and somebody is young, has a hydrated disc and it's bulging out, they're going to respond really well to that. If somebody's 65, they've got a little bit of a disc bulge, they've got less space due to narrowing and that disc shrinking, and the disc is dark black or desiccated on an X-ray, it's like a sponge that you throw on your counter and you go on vacation for a week, right? You can get some movement, you can get something in there because that disc is sort of like crab meat in consistency. But as you start to dry that disc out, the longer it's there and stays chronic, the harder it is to make movement to it. I always tell patients, the good thing about a disc, when they hear disc injury, they start to freak out and start, should I start my bucket list? No, I'm like, no, you'll be all right. Disc injury is so scary to people. But the good news is the disc is movable, right? So if you have a bone spur and it's compressing a nerve, that's really hard to treat from a conservative standpoint. But if you have a disc issue, the disc is movable. That's why that you and I can help these people, because the disc is movable. So you get it somewhat calmed down, somewhat retracted, and then you strengthen it, arguably the most important piece. That's how you fix that. And that's how decompression is used. If you don't strengthen it after, that disc becomes a chronic, once a year, twice a year, you go out and, hey, take that first golf swing. Boom, you're right back to it. But decompression, man, if it's spectacular. You can do the same thing in the neck. Not as much in the thoracic spine because you don't really get disc herniations there, but same thing in the neck.
Yeah.
Works fantastic.
My form of, it's just like a subox release with maybe some cervical traction.
So I'll do the same as well. Normally I'll start with that to see how they respond, because I can mitigate that with my hands. Now, the good thing about the table is it's variable, but once they're on it, it's not like, oh, that's too hard, let's calm it down. Normally we start very, very light and work our way up, and it's going to take every bit of probably 4 to 12 treatments to really get benefit out of it. But I'm going to do the same thing with the lower back, using maybe a lower extremity or my hands, because it's a great place to start, more gentle. You can get decent specificity with your hands, but there's nothing like a really specific decompression table that's pulling at a very specific weight for 25 minutes.
I like how you mentioned like the 60 to 30. It's like walking. Walking is such a healthy thing, right?
Exactly. And that leads me to the inversion conversation. I'm a huge fan of inversion tables if used properly. So most people are going to buy an inversion table. They're going to hook their feet in. They're going to flip all the way upside down, and they're going to hang there until they can't handle it. Blood rushes to their head. They have indigestion, whatever. And they just ate a big meal. They're like, this sucks. Like, I'm not doing this again. The way you do an inversion table that makes it effective, primarily for the lower back, the neck, this is not really going to happen. So you want to set it to 60 degrees. So there'll be a pin where you can stop it. Have you been on one before?
I have not.
Okay. So you hook your feet in. There'll be a pin on all modern ones that tell you where you stop. You can stop 30 degrees, 60 degrees, or you can let it go all the way down, right? So you want to start, you want to end up at about 60 degrees. Whether you start at 30 and work your way down to 60 to get tolerant to it, totally fine. But what you want to do is you want to hook your feet in, you want to start at neutral, horizontal, and you want to go down to 60 degrees for about 45 seconds. And I always tell people, get a timer on your phone, like an interval timer. Boom, it dings. You want to come back up to neutral for 15 seconds. So you got that minute cycle. You're going to go up and down about 5 to 10 times. 60 degrees is a good spot for a lower lumbar S1 issue, which is 86% of lower back issues are going to be in that region. So 60 degrees is really good. If you can't handle that, you can start at 30 degrees. One of the biggest keys is setting the pivot point. So if you share it and your wife uses it as well, you're going to have to shift that pivot point, meaning it's really challenging to go back. You want to throw both arms up in the air and you slowly go back. And as soon as you bring both arms up to your waist, it shoots you back up. Because like the number one
flying off or something.
Well, the number one thing people worry about is getting stuck at the bottom. And if you have that pivot point in the wrong spot, you might get stuck at the bottom.
That's not a fun place to be.
That's not a fun place to be. And not to mention, most people I'm telling this to just had an acute lower back, threw their back out, which leads me to another point. It's probably not a great thing to do. You hurt your back golfing this weekend. You got shocking, shooting, radiation down your leg. It's not a great place to start. Normally, all that spasm, the inversion table is not a great place. So what I always tell people is come in here, 2 to 4 weeks, get it calmed down, and then we switch. You're seeing me less decompression, less manipulation, more inversion at home, more therapeutic exercise at home. That's the kind of switch that I do in the ratio that I do.
Sweet.
Yeah, but it's the real deal, man. Yeah. It's the real deal.